Good morning, everyone. Today's topic is on cortical and cerebral vein thrombosis by Dr. T. Soumya. She is MD physician, practicing physician, and work now doing her ID system in Medicover Hospital under Dr. Mohan Maharaj. This topic is actually now very why we choose this nowadays. Actually, incidence of cases are going up, maybe because of changing of lifestyle and using the uh, uh, drugs which causing the cortical venous sinus thrombosis. Also, treatment part also it is evaluated like anything. Earlier we used to only low molecular weight heparin or unfractionated heparin, but nowadays because of there is so much of development in interventional radiology, people are doing thromboaspiration and even thrombolysis also, and presentation also. These cases will present in differently, unless we have a thought in the main suspicion, we will miss the cases by seeing the CT scan. With this introduction, I welcome Dr. T. Soumya to present today's topic. Over to T. Soumya.
Good morning. Today my presentation is on cortical or cerebral vein thrombosis. This thrombosis of cerebral veins and dural. It's a thrombosis of cerebral veins and dural sinuses in the brain, and which carries a significant mortality and morbidity, and with a varying clinical presentation. And this is the anatomy of the dural sinuses, where just I want to take a minute on this. These are the layers of below the periosteum, cranium. There are dura mater, then arachnoid mater and pia mater are there. And the dura mater is having two layers. One is the osteal layer and other one is the meningeal layer. And we can see here the meningeal layer and osteal layer between is the dural sinuses, and which when the meningeal layer takes the contour of the brain, the falx cerebri, tentorium cerebelli, falx cerebelli, or they are the in between these meningeal layer and the osteal layer, the dural sinuses lie, and below the meningeal layer there is a arachnoid layer where the arachnoid granulations will be protruding into the dural sinuses, and the blood vessels in the arachnoid space, and the CSF in the arachnoid space, and below that is the pia mater. And going to the anatomy of the dural sinuses, as I said, in the falx cerebri, there is a superior sagittal sinus, and there's a deep system, superficial cerebral vein and dural sinuses, and there's a deep cerebral vein and dural sinuses system is there. And the superficial superior sagittal sinus and superficial middle cerebral veins and the superior anastomotic vein and inferior anastomotic vein, they all called as superficial cerebral vein and sinuses. And the deep system is inferior sagittal sinus, then straight great cerebral vein, straight sinus, transverse sinus, then sigmoid sinus, and which cavernous sinus, and then into the inferior internal jugular vein. This is the deep system of the dural sinuses and cerebral vein system. And coming to this venous system, 60 to 70% of the blood will be in the venous system of the brain. And these dural sinuses, there is no musculature and no valves up to the jugular vein. And dural sinuses, they do not collapse. And also the transverse sinus, coming to the transverse sinus of the brain, right side is predominant, which carries 40%, and left side is only 80%. And coming to the incidence of the cortical vein thrombosis, it is uncommon, and with the annual incidence of 1.16 to 2.2 cases per 1 lakh. And it is more prevalent in females, and with the ratio of male-female ratio, female to male ratio 3:1. And the gender imbalance may be due to females they'll be pregnant, and in view of picparium and use of oral contraceptives, the gender imbalance is there. And coming to the younger individuals, they are more affected with a mean age of 37 years. And only small percentage of older individuals are being affected. Above 65, it is 8%. And there is a low risk for recurrence of CVT and venous thromboembolism of first CVT episode. And coming to the pathogenesis of the cortical vein thrombosis, there are two mechanisms. One is due to the thrombosis of the cerebral and dural sinuses, and there will be obstruction of the blood drainage of the brain tissue. And the mechanism I'll be telling subsequently. There will be a vasogenic and cytotoxic edema. That is one of the mechanisms. And the second is due to occlusion of the dural sinuses, there is decreased CSF absorption, which in turn raises the intracranial pressure. That is the second mechanism. And how do they cause mechanism is the obstruction of the venous structures cause increased venous pressure, and in turn increase the capillary pressure, and there is a decreased capillary perfusion pressure and increased blood volume. And this raise in venous pressure will increase the local edema, and also there will be a leak of blood plasma into the interstitial spaces, which causes vasogenic edema. And because of the local cerebral edema, there will be venous hemorrhage will be taking place, and capillary rupture and venous hemorrhage will be taking place. Along with that, there is a decreased cerebral perfusion pressure because of the increased venous pressure, and there is failure of energy metabolism, sodium, potassium, ATPase pump failure, and the cytotoxic edema. This is how the cerebral edema and venous hemorrhage will be taking place. And coming to the second mechanism, where there is a normal CSF absorption occurs usually in the arachnoid granulations, and there will be the lymphatic system also in the arachnoid space, which helps to clear the CSF. When there is a dural sinus thrombosis, there is increased in venous pressure, and there is a decreased absorption of CSF, and in turn there is a raise in intracranial pressure. And these are the two mechanisms where were the cause of cortical vein thrombosis, and where there's a blood-brain barrier disruption and hemorrhage takes place. And coming to the risk factors of CVT, the most common risk factors are in adults include prothrombotic conditions like genetic or acquired, or obesity, or the use of oral contraceptives. And more than 85% of patients of CVT in adults, at least they'll have one risk factor. Either it's inherited or acquired prothrombotic condition. In Canadian pediatric ischemic stroke registry also found risk factors in 98% of children. And coming to the age-specific risk factors, individuals age 65 and older with and genetic and acquired thrombophilia, malignancy, neurological disorders are more common. And acquired risk factors are pregnancy, puerperium, use of oral contraceptives, malignancy, and obesity. These are all acquired. And gender specific or female, mostly they take hormone replacement therapy and estrogen receptor modulators like tamoxifen. So these are gender specific. And obesity is a risk factor for CVT and other venous thromboembolisms, especially in females who are using oral contraceptives. And coming to genetic thrombophilia, prothrombotic conditions like factor V Leiden mutation, prothrombin gene variation, and antithrombin deficiency, protein C proteinase deficiency, hyperhomocystinemia. With the backup of these prothrombotic conditions, if they get exposed to the precipitating factors like head trauma, surgery, or infection, they can have CVT. And also other risk factor, COVID-19 vaccination. COVID-19 experience CVT in 0.08% frequency with a 40% of hospital mortality. And COVID-19 vaccine thrombosis is also been observed, which is more with AstraZeneca and our Indian Covishield and Janssen. And this is similar to heparin-induced thrombocytopenia. And the timing of the vaccine-induced thrombosis is 5 to 30 days after vaccination. And even with the second dose of AstraZeneca, they observed. And the other risk factors of CVT are head injury, inflammatory disease like inflammatory diseases, which they increase the CVT. And there is a cryptogenic CVT where we don't find any cause, and it is less than 10% in children and 13% in adults. And older age people, they have a higher proportion of cryptogenic CVT of 37%. And coming to the presentation of the CVT, the presentation may be acute, subacute, or chronic. Acute is like less than 48 hours is acute, and subacute is 48 hours to 30 days, and chronic is more than 30 days. And the common symptoms are new onset of headache, intracranial hypertension, neurological deficits, seizures, and encephalopathy are the common presentations, and less common are cavernous sinus syndrome, subarachnoid hemorrhage, and multiple cranial nerve palsies are the less common presentations. And 89% of the patients, they have headache, which may have, the headache will worsen with Valsalva whenever, and it will resemble, it can resemble migraine or a thunderclap headache. Even it can persist after doing lumbar puncture also. They'll get headache in these patients. And patients with isolated intracranial hypertension with CVT, which occurs usually in the chronic cases. with visual problems and papilledema. And the other presentation is seizures. Either it can be focal or generalized. And 39% of them, they present with seizures, and which is mostly associated with supratentorial brain lesions and sagittal sinus and cortical vein thrombosis. And coming to the encephalopathy of the presentation, they can have disturbed consciousness, cognitive dysfunction, and multifocal deficits. And the focal syndrome is by weakness like monoparesis or hemiparesis. They can have aphasia, sensory deficits, and visual field defects. And sometimes they can present like syndrome of isolated sinus vein thrombosis, which is like in cavernous or cortical vein or lateral sinus thrombosis. They have a diverse clinical presentation like cranial nerve palsies will be there. And coming to the neuroimaging, we will find focal edema or venous infarction or a hemorrhagic infarction or a diffuse cerebellar edema or subarachnoid hemorrhage will be seen. And we can diagnosis is by CT or MRI or MR venogram are the key diagnostic tools. And when we see a CVT case, we do urgent imaging, MRI or MR venogram if possible, or not, we can do CT imaging also. But when we do CT brain, 30% of cases, the CT brain may be normal, and the signs of CVT are, I'm showing here. There are 3 signs: cord sign. See here we can see this is a cord sign, and empty delta sign or dense triangle sign will be seen in CT imaging. And indirect signs like contrast enhancement, dilated veins, and parenchymal abnormalities also can be seen on CT imaging. And this is a slide where we can see the cord sign and the frontal area on the left side. And coming to the MRI and MR venography, they are more sensitive for CVT, and T2 images are very sequences we will be looking at a lot. On T1 in acute, usually the MRI findings are like if it is less than 5 days on T1 the thrombus, if there is a thrombus on T1 weighted, we will see iso-intense lesion. On T2 weighted, we see hypo-intense lesions. On if it is more than 5 days on T1 and T2, they'll become iso-intense. And if it is more than a month, they'll be iso-intense. And if it is more than 5 days, it is there'll be hyperintense lesions will be seen when there is a thrombus sinus is there. And coming to the conventional angiography, it is reserved for high suspicion cases only, where the CT and MR venogram are inconclusive. And the typical CVT signs are corkscrew veins and venous flow reversal is there. And coming to the laboratory testings, normal standard blood testings like blood counts, chemistry panel will be done, prothrombin and activated PT with INR and APTT will be done. And elevated D dimer supports the diagnosis of CVT, but it doesn't exclude CVT. And D dimer is a screening tool when combined with clinical symptoms and risk factors. Coming to the other tools of investigations, lumbar puncture. It can helps to rule out the meningitis. and also it helps to relieve the intracranial pressure in isolated intracranial hypertension, but it is not a diagnostic tool. And coming to the CSF abnormalities, in 30 to 50% of patients, most of it is non-specific, which is with lymphocytic pleocytosis with elevated RBC and protein. And we need to evaluate the next test is evaluate the thrombophilic state, like screening for antithrombin deficiency, protein C and protein S deficiency, and fatty phyllidin, prothrombin G20 to 210A, glucose anticoagulant, APLA, anti-beta 2 glycoprotein 1 antibodies, and hyperhomocystinemia, or the thrombophilic test to be done. But for antithrombin and protein C, protein S testing, it will be best performed after discontinuation of the oral anticoagulation. That I will discuss later. And in spite of doing this many investigations, 13% of the adult CVT patients, we cannot find the identifiable cause. And we need to follow up this type of cases, whether we can find any cause. And the additional recommendation regarding the testings are repeat testings of APLA biomarkers if initially abnormal, and consider evaluation of paroxysmal nocturnal hemoglobinuria in specific cases where they can have a hemolytic picture. And we need to look for occult malignancy in CVT patients over 40 years of age. And perform lumbar puncture if there's an unexplained fever and suspecting sepsis. And coming to the differential diagnosis of cortical vein thrombosis, when a patient presents with headache and papilledema, like a intracranial hypertension syndrome, the DDs would be idiopathic intracranial hypertension, meningitis, and structural intracranial lesions can also cause headache, which can be excluded by neuroimaging. And if a patient presents with focal neurological syndrome, the other DDs to be considered are intracerebral hemorrhage or ischemic stroke, and infections like meningitis and abscess and tumors. And when a patient presents with encephalopathy signs, the DDs would be like infections like bacterial and viral meningoencephalitis, and inflammations like paraneoplastic and autoimmune encephalitis, and demyelination like acute disseminated encephalomyelitis and neuromyelitis optica, and toxic and metabolic disturbances. And when the patient is having thunderclap headache, which is rare in CVT, but the DD will be, differential diagnosis will be subarachnoid hemorrhage, and any other sudden intracranial hemorrhage to be ruled out. And coming to the treatment of the cortical vein thrombosis, it covers mainly the aim of the treatment is to achieve the recannulization, prevent the thrombus extension, and address the underlying prothrombotic condition. And coming to the anticoagulation, coming to the treatment, the mainstay is anticoagulation. We can administer subcutaneous low molecular weight heparin or intravenous heparin. And hemorrhagic infarction and intracerebral hemorrhage is not a contraindication for anticoagulation. Subcutaneous low molecular weight heparin is preferred over unfractionated heparin. And in pediatric age group also, the treatment is same. For heparin-induced CVT with heparin-induced thrombocytopenia and and in COVID-19 vaccine related thrombosis causing CVT. Like in COVID-19 CVT, vaccine-related CVT, where usually it happens between 5 to 30 days of vaccination. And here the treatment in both is give either a direct oral anticoagulant or fondaparinx or a thrombin inhibitor like argatroban and intravenous immunoglobulin. Because here the platelet factor 4 autoantibodies will be developed. So heparin is not cannot be given. Low molecular or unfractionated heparin cannot be given here. And in these patients, there is thrombocytopenia, and unless there is a significant bleeding is there, platelet transfusion is not indicated. And studies have shown regarding the anticoagulation, low molecular weight may be more effective and equally safe as unfractionated. And substantial evidence supports the safety and efficacy of anticoagulation in adult patients with CVT who have associated intracranial hemorrhage, either intracerebral or subarachnoid. And they observed a new intracerebral hemorrhage is not common in CVT patients who are treated with anticoagulants. And pediatric also, not much difference. It's the same only. And coming to the next treatment, it is endovascular treatment of CVT. And it is considered only for some specific cases where neurological symptoms worsens despite adequate anticoagulation with low molecular weight or unfractionated heparin, where we opt for endovascular treatment for CVT. And the methods are and devices are endovascular treatment are like balloon angioplasty, mechanical thrombectomy, stents and microsnares, often combined with the local thrombolysis to remove the clot, which are blocking the cerebral veins and dural sinuses. And efficacy, coming to the efficacy of this endovascular treatment, the studies have reported a promising outcome with up to 84%, achieving the favorable result with a high successful recanalization. There's a trial called 2-act trial. It's a randomized control trial. But it didn't definitely establish any superiority of endovascular treatment over anticoagulation. And coming to the mortality and the complications of endovascular treatment, the mortality rates to be found higher in patients with this approach. And also complications like major bleeding and intracranial hemorrhages are also being observed. And considering of the decision is to pursue endovascular treatment should be made carefully, taking in account of the patient's clinical presentation and assessing the potential benefits. And coming to the acute management issues of CVT, managing the elevated intracranial pressure by which occurs usually in the large hemorrhagic lesions and with large infarcts and with the cerebral edema in acute CVT. And also we observe elevated intracranial pressure with transtentorial herniation. CVP may lead to transtentorial herniation in the life-threatening condition. Ventricular shunting is not recommended here for treating acute hydrocephalus. And coming to the endovascular intervention, already I discussed. And for the neonatal patients, we consider anticoagulation, especially when they show clinical deterioration or thrombus extension on imaging. Serial imaging at 5 to 7 days should be considered if anticoagulation is required. And coming to the intracranial pressure control, we keep the head and elevation. We sedate the patient, mild sedation, and also give osmotic therapy, either mannitol or 3% NaCl, and controlled hyperventilation targeting PCO2 between 30 to 35, and ICP monitoring. And hemicraniectomy is another life-saving option in patients with impending herniation due to unilateral hemispheric lesions. And therapeutic lumbar puncture will be considered with signs of intracranial hypertension, potentially when there are visual symptoms and headaches. And the safety of the LP, it has to be assessed case by case only. And coming to the glucocorticoids, it has no role, like intravenous dexamethasone is not recommended until unless there is inflammatory diseases like Behçet's and SLE is there. We don't consider glucocorticoids. And coming to the anti-seizure medication, anti-seizure medication will be given in the patients who present with seizures and supratentorial lesions like edema, infarction, or hemorrhage on CT or MRI. And patients with seizures at presentation with supratentorial brain lesions have a higher risk of developing early seizures in CVT. And the drug of choice will be the valproate and levetiracetam over the phenytoin, as phenytoin may be interacting with the oral vitamin K antagonist anticoagulants like warfarin. And the management of the acute, after acute the CVT, after the acute phases, like infections and inflammations are to be managed by antibiotics. And as I said, glucocorticoid has no role except Behçet's and lupus. And coming to the anticoagulation, long-term anticoagulation, they need most of the adults with CVT, we need to continue the anticoagulation either with warfarin or a direct oral anticoagulant. Direct oral anticoagulants are more preferred over warfarin because warfarin needs INR management, which has to be maintained about 2.5. And anticoagulation in malignancy, avoid low molecular weight heparin in patients with severe kidney disease who have a creatinine clearance of less than 30. And in malignancy, we prefer low molecular weight heparin. And in renal failure, oral anticoagulation is preferred over no therapy. And the APLA, we prefer warfarin in CVT patients. Renal failure, severe renal failure, we should avoid direct oral anticoagulants. And vitamin K antagonists like warfarin are preferred over the direct oral anticoagulants. And in pregnancy, for long-term anticoagulation during pregnancy, heparin are safer than oral anticoagulants. Warfarin and direct oral anticoagulants are contraindicated during pregnancy. And for children in CVT, we can give low molecular weight, vitamin K antagonist, unfractionated or direct oral anticoagulants. And the duration of anticoagulation is 3 to 3 months after the acute phase minimum. And we can tailor the duration based on the prothrombotic risk factors, whether they are provoked or unprovoked or a severe thrombophilia. And we generally avoid using aspirin for long-term CVT management unless there is any specific reason or indication. And anti-seizure medication for patient with seizures after hemispheric CVT. The duration is determined based on the patient seizure history. And for headache, we do give drugs which decrease the intracranial pressures like escitalopram and topiramate, and interventions like lumbar puncture and shunts and stenting. And if the patient is having any visual loss from cortical vein thrombosis, we need to rule out the elevated intracranial pressure. If there is an intracranial pressure, instead of going for shunting, they go for fenestration of the optic nerve sheath, which will release the pressure and the worsening of the eyesight. And coming to the patients with cognitive and psychiatric complications, we need to encourage the patients so that they resume their activities and jobs, and antidepressants to be given if needed. And regarding the subsequent pregnancy, for those with history of CVT, prophylactic low molecular weight heparin during pregnancy and postpartum period is suggested, and which reduces the risk of recurrent CVT and venous thromboembolic events. And avoid warfarin during pregnancy. And oral contraceptives warn CVT patients, females, regarding the increased risk of venous thromboembolic episodes and recurrence of CVT. Emphasize lower risk options like contraceptives, which are the second generation progestins, like levonorgestrel. And coming to the prognosis and early mortality in CVT, CVT has a favorable prognosis, and 5% of patients die in acute phase. And predictors of early mortality are altered mental status and depressed consciousness, deep vein thrombosis, and right hemisphere hemorrhage and posterior fossa lesions. These are the predictors of early mortality. And early deaths would take place in mostly with transtentorial herniation and large hemorrhagic lesions. And the primary causes of acute death include transtentorial herniation, large hemorrhages, and multiple lesions, and diffuse cerebral edema, with patient present with status epilepticus and medical complications and pulmonary embolism. And mortality after acute phase of CVT is mainly related to the underlying condition only. And there is a study called International Study on Cortical Vein and Dural Sinus Thrombosis, where the 15% overall death or dependency rate at the end of the follow-up, which varied from 3 to 78 months. And 79% of patients experienced complete recovery at the end of the follow-up in this study. It's a study done between 624 patients, CVT patients with 16 months of follow-up. And the predictors of the poor long-term prognosis are the same as I said before: right hemisphere hemorrhage, posterior fossa lesion, central nervous system infections, malignancy, DVT, and GCS less than 9 with a mental status abnormality and age of more than 37 years and a male sex. And there's a CVT risk score is there, which estimates the prognosis at 6 months. At the end of 6 months is based on points. Malignancy carries 2 points. Coma on admission carries 2 points. DVT 2 points. And mental status disturbance on at admission carries 1 point. Male sex 1 point. Intracranial hemorrhage 1 point. And if the score is more than 3, 3 or more than 3, it indicates poor outcome, and which has a high sensitivity and a low specificity. And female patients generally have more favorable outcomes who are affected with CVT in view of the sex-specific risk factors. And intracerebral hemorrhage at diagnosis is found in 39% of cases of CVT with older age and male sex and deep cerebral venous system and lateral sinus thrombosis and motor deficits. And good outcome is observed in patients with CVT with only symptoms of intracranial hypertension. And coming to the recurrence of the CVT or venous thromboembolism, it is 2 to 4% recurrence in CVT and 4 to 7% in venous thromboembolism. As I said, the ISCVT study done between 624 CVT patients, the recurrence of CVT is observed as to 2% and 4% for the other thrombotic events. And long-term data suggests 4% recurrence of CVT and 7% of vascular thromboembolism is also long-term data was suggesting. And in prospectus, and there's another prospectus study done in 145 patients for 6 years who are on anticoagulant therapy. 3% had post-anticoagulant therapy, 3% had recurrent CVT, and 6% had vascular venous thromboembolism. And the risk of CVT or venous thromboembolism were 0.5 and 2 per 100 years respectively. And the risk factors of CVT recurrence in adults are history of prior venous thromboembolism, polycythemia, thrombocythemia, clinical history or laboratory evidence of any thrombophilia, male sex, and black race. Coming to the recanalization of the CVT, most patients of CVT experience some degree of recanalization. Overall, 80%. Complete recanalization. And the factors of recanalization include thrombosis and superior sagittal sinus, thrombosis, and female sex. And the negative predictors of recanalization include multiple thrombosis, hormonal therapy, old age, and absence of identifiable risk factors for CVT. Thank you.
What are the interventions?
Thank you, Soumya. Nice presentation. Sir.
Radiology interventions ఏమేం చేయొచ్చు సార్?
Sir.
Radiological Soumya.
Sir. Right. Yamanar, sir.
A few centers they are doing this, sir. Mechanical thrombectomy also, sir.
CMC
depends upon the
studies are there, sir.
Dr. Soumya, good presentation. So now a patient has come with a stroke or a bleed. To the hospital. Hello?
Sir, yes, sir.
A patient has come to the hospital with
Yes,
a stroke and is ischemic stroke or like bleed or something. It's a
Okay.
bleed. So how will you identify, so to that patient, a patient coming with a bleed, in this patient, do you do every patient MRI or how will you identify CSVT is there or not?
Sir, if it is arterial bleed, it will be like middle cerebral artery or anterior or posterior cerebral artery. It will be confined to that area. But if it is a venous, it won't be confined to the arterial areas, sir. That's how we recognize the arterial or venous bleed. Is this what, sir?
Yeah, I agree. You are right. So basically, we need to look into the distribution of the artery where the bleed is suspected. If that is not there in that area,
Yes,
definitely we need to suspect the CSVT and we
Yes.
need to investigate.
yes, sir.
Yes. Can you tell the areas where do you suspect?
Sir,
Can you tell the areas where do you suspect?
ఇది కనిపించట్లేదు.
వినిపించట్లేదా?
వినిపిస్తుంది సార్. No, don't stop sharing. సార్ చెప్పండి సార్.
What are the areas where do you suspect?
The venous.
అదే అదే వీనస్ ఆర్టీరియల్ లేదన్నారు కదా, సో అది ఎక్కడ అని.
అంటే we have artery, anterior cerebral artery, posterior cerebral artery and middle cerebral artery areas will be there less.
అయితే సౌమ్య సార్ యాక్చువల్గా అడుగుతుంది కమింగ్ టు ద వీనస్ దట్ డే వి డిస్కస్డ్ నా విచ్ ఏరియా యాక్చువల్లీ is more common according to that venous circulation.
I think Sir is asking about arterial bleed, sir.
Arterial.
No,
Srinu?
I'm not asking about arterial bleed. I'm not asking about arterial bleed. Which areas, if the bleed is there, you suspect the venous? So is it clearly we have mentioned that which is not in the arterial distribution areas. So
Usually
what
that's
is not
called
in the arterial distribution areas?
watershed zone they'll say lesser.
అదే దానికి ఏరియా ఉంటది అమ్మా, ఇప్పుడు ఫ్రాంటలా, టెంపోరలా, ఆక్సిపిటలా, లేకపోతే
You have shown few images కదండి సౌమ్య గారు.
అవును సార్.
మరి ఆ ఏరియాలో ఎక్కడ ఉంది
అది కార్డ్ సైన్ అవన్నీ వేసి ఇన్ ద ఫ్రాంటల్ ఏరియా ఒకటి చూపించాను సార్ నేను. తర్వాత bleed is mainly along the cerebral veins area, sir.
Okay.
No, because here the treatment is very important. The patient will have a bleed and we don't suspect the bleed, we don't suspect CSVT and we don't give a low molecular weight heparin. So the treatment is not completed until we start the low molecular weight heparin. That's the reason. So basically, as per my knowledge, it is mostly present on the peripheral areas. So arterial distribution will be more in the center. Okay. And specifically ante we usually internal capsule area ఇది ఉంటాయి, otherwise cerebellar ఇది bleeding ఉంటుంది, but most of peripheral zones where we don't see, then we need to strongly suspect that.
Okay, sir.
One more thing is actually the venous bleeds usually we have to correlate with the symptoms also. So compared to arterial bleeds. So these people we have to take history also after seeing the CT scan regarding the history of taking of pills. Apart from that, these people suffers from headache from the long history of headache and symptoms of intracranial hypertension. And moreover, these people present with a focal syndromes. Few people, if deep venous system is involved, they will present like a diffuse encephalopathy and coma. And also depends upon the the sinus means like if suppose cavernous sinus involved, they will present with a painful ophthalmoplegia and cranial neuropathy also. So depends upon the area, these people have a specific symptoms. Suppose superior sagittal sinus thrombosis occurs. This is present with focal hypertension, focal symptoms, aphasia, and seizures. Suppose deep venous systems involved, they have a reduced arousal, coma, and one interesting thing is for presentation point is bilateral and fluctuating alternating motor deficits. This is one of the characteristic features in deep venous systems. See, patient tells today my right hand is not, that means weeks or next day or after few hours, maybe they will tell opposite hand. Maybe because of changing of the this pressure. This is also interesting thing. And when the patient transverse sinus involved, completely aphasic, seizures, and they will present with cranial nerve paralysis and ataxia also. And when sigmoid sinus is involved, these people present with like lower cranial nerve neuropathies.
Sir, I didn't get you, sir.
Depends upon the not only these things symptoms wise, the patients will present. And moreover, this more than two sinuses involved. Not a single sinuses involvement is very rare. Coming to suprasagittal with transverse sinus or a sigmoid sinus, like that, these people will present. Any questions from any audience?
Sir, one thing I'll add, sir. So what we are doing is in our hospital, we also have a stroke specialist here, trained specialist in our hospital. So a patient coming with a bleeding or clotting, whichever is the mechanism, which is less than 4.5 hours. We are doing both CT venogram and arteriogram in that patient because this patient is in the window period and this may require a thrombectomy, thrombolysis and thrombectomy. So just standardly we are putting it here. And we are finding out bleeding with the CSVTs also sometimes. Standard protocol. If suppose the patient comes out of window period, we are doing an MRI. So this is, we have put a standard protocol, sir. We are not missing.
Yeah.
So why? Because we wanted to look into the thrombectomy path also. That's the reason why we are doing this. Right. Thank you, sir.
Yes, sir.
Presentation. Huh?
CT with CT arterial and venogram. Same thing we are also doing.
Amount of message should డాక్టర్ సౌమ్య మెసేజ్ చూడండి.
చూస్తున్నాను సార్. మన డిపార్ట్మెంట్ దాంట్లో పెట్టారా సార్?
జూమ్ మెసేజ్.
ఓహో, జూమ్ మెసేజా సార్? Moderators not seeing message.
Okay, Mishram.
The treatment of first choice for peace.
Okay, sir. So there are four.
ఏమన్నా సార్? సార్ ఏమైనా క్వశ్చన్ అడిగారా సార్? What percent is idiopathic? Um, 18% I remember, sir. Idiopathic.
I think you said 13%.
13. Yeah. What are the different complications of heparin, low molecular, and acetylene? Complications with heparin and low molecular weight. One is Hitzer, but that is very rare. And in CVT patients, hemorrhage is not a contraindication to be given. Hemorrhage means cerebral hemorrhage. With acetylene, pregnancy and all cannot be given acetylene, otherwise it can be given. But with acetylene, the INR has to be maintained 2.5 or above.
Students can answer. Any another students? Swati, Mahesh, what are the complications with low molecular weight heparin and acetylene? Cherishma,
Anyway, time is getting up. Just understand with the hit of heparin and low molecular heparin also can cause hit. And acetylene will have a duration of changing of the time as well as the INR maintenance is very high and it's not going to work differently. The drug and drug interactions are more with acetylene. And the ratio of male-female ratio is almost 1:3. Ratio of females is more, as Soumya said rightly.
And male one.
Yeah. And the choice of every intervention is including the CSVT or pulmonary embolism. Now it has become a first choice of intervention when you have availability of, just like a cath lab, when you have a cath lab intervention, it becomes intervention is more important, except first 3 hours if the choice is there. Same way here, even intervention radiologists are available and equipment is available. The intervention is more important than the thrombolysis or giving the drugs for any thrombus, CVT or pulmonary embolism. Thank you.
thank you, Soumya.
Thank you, Soumya. Thank you, Monroe.
Next class is on neuro monitoring by Swati from Medicover Hospital. Can I close,
Okay.
sir?
Yeah, thank you. Anybody else?
Yes, sir.
No, anybody else want to speak? I thought I'll ask nothing else. Thank you.
Thank you, sir. Thank you, Soumya.
Thank you, ma'am.
Please share your PPT in the group, Mama.
Okay, sir.